Hello, my dear doctors. I'm gonna wait a few more minutes for you to gather up. I know it's a Saturday. Hello, Besher. I was just talking to myself until you entered. How are you? Oh, nice to hear that. Okay, let's just wait a few more minutes if Ed and others join us. Please go ahead if you have a question. Yes. So what do you need to study on? Let me open up the syllabus and you will get it. You mean the focus, okay? So you definitely need to read the book, but what to focus on actually, the PPTs give you a hint for that, okay? So midterm was till the first one was till week 6 material. Now we started with the week 7 with the introduction of the genetics, which is chapter 2 and 10 in the Snurstad and Simmons, and the chapter 2 in the Thompsons. The next one was the human genome, the central dogma, so on. Again, the chapter 11 from the Principles of Genetics and chapter 3 from the Thompson, if you choose one of the two books. Then we went through, in the previous weeks, we finished the methods, which are tools of the human molecular genetics, again from the chapter 14, both of these parts, both of these 2 weeks material. And we talked about cytogenetics in previous Saturday. This part will be also included in the second midterm, which is chapter 5 in the Thompson and Thompson and Thompson. And today we're going to talk about the clinical genetics, chapter 6, and we're going to start chapter from 7 from the Thompson and Thompson, patterns of the single gene inheritance, okay, which is I have divided into 2 PPTs. So today we're going to go through this part, but only this part will be included. So it will be, I think, more fearful, since you had 6 weeks material and then first mentor. The rest 6 will be in the second midterm. It means week 7, week 8, week 9, week 10, week 11, and week 12. Okay, so until here we have already talked about till past week. Today we're going to talk about clinical cytogenetics and patterns of the single gene inheritance, but only 12-week material will be included, starting from week 7 till week 12, okay, including 12. Okay, like this. My writings? No. The first 2 hours will be on the midterm. The others will be, this part will be on the midterm. Today we're going to talk about the first 2 hours. But as you have noticed, today we have 4 hours lecture. It means we're going to discuss patterns as well, which is not going to be on the midterm, but it's going to be on the final exam, okay? So this one, we're going to talk first 2 hours. It will be on the midterm. And this one will be on the exam, including 13, 14, and 17 will be on the finals and not on the midterms, okay? but it doesn't mean you can skip it now, because it will be on the final exam. Today we're going to discuss these two. From just this one will be on the midterm, but this one on the finals. And next week, which is going to be the last week in this first semester, we're going to talk about these two. Okay, so we are in a hurry because we have limited time. This is the before the holiday. We only have 1 week left, so I'm going to discuss two chapters together. Can you tell us the name of the books that we study? Thompson. So why I opened up the syllabus, it is because under each of the chapter we have the reading. Okay, I'm using these two books, Principles of Genetics by Snusted and Thompson, and Thompson Genetics in Medicines. Okay, I have combined those two in my PPTs, but for example, for methods, this part 9 and 10 week, I only use chapter 12, but chapter 14 out of the first book. Okay, so I think if you study from the Principles of Genetics, this part, but cytogenetics, you can see there is no option in here. So cytogenetics comes from the Thompson and Thompson, so you definitely have to use this book as well. Okay, so these two books, especially for today's chapter, we're gonna go Thompson and Thompson, but for the methods you use the Principles of Genetics of the Snusted and Simmons, and for the central dogma as well. Okay, for the rest of the chapters you can use Principles of Genetics by Snusted and Simmons, and just for the cytogenetics use the Thompson and Thompson. Okay, and I mean clinical cytogenetics as well, chapter 5 and chapter 6. Okay, this is chapter 14 and 9. So okay, I will start from the beginning. 7 week introduction to genetics. Use chapter 2 and 10 out of the Principles of Genetics. So like this. Okay, then chapter 8, the human genome. Use the chapter 11 from this Snusted and Sims. Okay, then methods, which is which is 9th and 10th week. This is just the chapter 14, one chapter out of the Snusted and Simmons again. And the last two, cytogenetics and the clinical cytogenetics, different book, Thompson and Thompson Genetics in Medicine. This is chapter 5 and this is chapter 6. Okay, so in total you've got two chapters, 5 and 6 from Thompson and Thompson. You've got 14 from the Snusted, 14, 11 from the Snusted, 2 and 10. 4 chapters from Snusted and Simmons, 2, 10, 11, and 14, and 5 and 6 from Thompson and Thompson. Okay, are we clear now? The last question, I haven't made the first. Oh, you haven't made the first exam. I don't know what to tell you at this point, because I wasn't with you with the first midterm as well, because I started from the week 7. I think you better write to Salome Chipurdanidze for that, and she will help you with that. Maybe you can retake it, or I don't know. Okay. Thank you for your question. Oh, I see the others have joined us. Welcome, Maria, Marino, Mohammed. Yeah, we were just discussing the topics for the midterm. You know, next week is the midterm. Okay, so I guess everything is clear now. We cleared the cleared the topic finally. Yeah, and I think we have 4 hours today. So today, in the first 2 hours, we're going to talk about the topic which will be included in the second midterm, and the next 2 hours we're going to talk about the part where it's included in the final exam. Okay, So I'm just gonna start it because we have a long way today, and I know it's Saturday. Everyone wants to relax, and I'm just after my night shift. So actually, before we started, I wanted to show you. Yeah, previous week I remember I talked about the surgery we performed, the scoliosis, if you remember. So I wanted to show you outcome. So this was type 4 scoliosis, a 17-year-old female. See the vertebral column. It should be like this and like deviated, deformed. No, this is the other. So this is the vertebra CT of hers. The lungs are compressed at this side. The breathing was difficult. She got tired really easy. This is this 3D reconstruction of CT. Like you see, the thoracic cavity is deformed and the ribs are deformed. Like you see, this is from the posterior view, and this is anterior view, the ribs and yeah. And this is the electrophysiologic monitoring we used during the surgery. It's very long and dangerous surgery. One wrong move, if you hit the nerve, you leave the patient paralyzed, because the thoracic segment of the spinal cord is the one that controls the movements in all of the limbs, not just the legs, but the hands as well. Okay, so very dangerous surgery. So that's why we put the electrodes on the muscles of the hands, on the legs, on the thoracic dorsal muscles, and we control the impulses by using this. So on this, you see the potentials here. And if there is any change in the potential, it just gives us a signal, and we just stop and move to the different direction. We just leave that spot. Okay, but fortunately we had no such encounter during the surgery. Everything went smooth and well. And now let's see them. So you see, remember, I will remind you. So this is the okay, I should answer this one, and I will show you poster pictures of that. Okay. Алло? გამარჯობათ, ნანიკო, როგორ ახართ? კარგად. Oh, very interesting case. My fellow ICU doctor called me, the patient post-op after the routine hernia discectomy, so-called, and he has the severe abdominal pain, epigastral pain, and the hiccups. And she was asking, could it be related with the lumbar discectomy? But it could not be, but it could be positional because the patients are lying on their stomach during the surgery. Maybe the mechanical yeah, I'd say irritation of the diaphragm and the nerves. Very interesting. I should look into it. I read something. Sorry for this. Um, but yeah, yeah, doctors, and you will get used to it when you're gonna be a doctor as well. Okay, so let's start with the cytogenetics. Um, Let me share the PPT with you. Okay, so as you can see, this is from the Thompson chapter 5. So if you don't have the syllabus, you can use the PPTs because with the contents, I have always everywhere included the textbook which you should use for the specific chapter. Okay. So we're going to talk about the cytogenetics. Briefly, we talked about clinical cytogenetics. What does it mean in the previous lecture? But today we're going to talk about the chromosome abnormalities, with studies of the chromosomes in the human meiosis and Mendelian effects. Where have we talked about this? I think we have talked about this in previous lecture. Did we? Do I remember it correctly? Did we talk about the bandings? Anyone? Someone? Please help me. I have a failure in my memory. No, we haven't. Okay, then I'm gonna start. Okay, so first, let's define the clinical cytogenetics. What does that mean? So it's the study of the chromosome, their structure, their inheritance as applied to the practice of the medical genetics. So it means I think we have talked about it. Yeah, I definitely remember talking about it. Yeah, so we talked about genetic disease, how we take the venous puncture, how we take the biopsies, and we can obtain from the placenta. We talked about briefly about the bandings because I will not include many of them in the midterm, just the G banding and Q banding and R maybe. This part will not be included. Fish, you should know the definition of the fluorescence in situ hybridization and why we use it and where. I talked about the aneuploidy, a definition of it, and euploidy. I remember that clearly now. And we talked about triploidy and trisomies. What is the difference between those two? Triploidy means to having a three copies of the whole genome, while the trisomy means having an extra chromosome, like the 21st trisomy, 21st chromosome trisomy during the Down syndrome. Okay. Triploid and tetraploid sets. We talked about the monosomy, like the Turner syndrome, 50 chromosome monosomy means one copy, only one copy is present. And we talked about balanced and imbalanced abnormalities. And balanced one is that the total number is not changing. We've got 23 pairs, 46 chromosomes, 22 autosomes, and one pair of the sex chromosomes X and X in females and X and Y in males. And balanced one, it means we have an extra chromosome or we lack the chromosome. It means additional or the missing material. And balanced one, we talked about the deletions, and we talked about duplications, the ring chromosome, chromosome. I remember that. Dicentric chromosomes, 2, and balanced rearrangement, inversions, translocations, could be reciprocal or Robertsonian. Robertsonian translocation could be also the reason of the Down syndrome as well, in 2%. Reciprocal means the change between it was 2 chromosomes usually, and one break happens at each arm of the chromosome. They just simply exchange the parts, and while Robertsonian, the break happens at the centromere part, so it means they exchange with the whole arm. Okay, and insertions, mosaics, we've talked about these. That's quite it. Okay. All right, now you should, yeah, thank you for your response, but yeah, we talked about it. Now let's open the clinical cytogenetics. So that was just the general part, and clinical part we're gonna go now. Okay. Okay. So this is the chapter 6, the last part that will be included in the second midterm. Okay. So, what are the general features of the chromosomal disorders? So, they're associated with the absence of genetic material in case of deletions of the segments of the chromosome, or could be deletion of the whole chromosome. In this case, we've got the monosomy. It means we have only one copy of this chromosome, not the pair, but the copy, one copy. Or having an excess genetic material, like in case of duplications, or in case of trisomies, duplication of the whole chromosome, the entire chromosome, like in case of trisomy of the 21st in Down syndrome. We have abnormal rearranges like translocation, reciprocal, or Robertsonian, and these are all the chromosome disorders. And loss of chromosomal material produces more severe defects than the gain, because to have a new feature is not always that bad than to lose the function you already have. Okay, like the loss of the function, also the function of the proteins could be in case of the enzymes, for example, perform a specific catalytic or specific reactions cannot perform that. So loss is more severe than the gain of the new feature. Okay, but excess chromosome material could be the complete chromosome in case of trisomies, or could be just the part of the chromosomes, like Robertsonian translocation, you're having a new part, or it could be during duplication, the 2 segments of the same genes, maybe. Imbalances of the sex chromosomes and are tolerated much better than the imbalances of the autosomes. Autosomes are the 22 pairs, and the sex chromosomes, like X and Y, are just 2 of them. So these imbalances between those two are less severe and more tolerated than the imbalances between the autosomes that lead to severe consequences like the mental retardation or the physical retardation, and so on and so forth. Okay. And the sex chromosome disorders, like they are subtle abnormalities and not detected at the time of the birth, but also some of disorders like the Down syndrome, they are easily detectable with the features, clinical features, even at the time of the birth. De novo changes, other than the mutations, we've got de novo changes that are usually not inherited but appear newly, sporadic cases, okay. So let's talk about the autosomal disorders first, and then let's discuss the sex chromosome disorders. So numerous rare chromosome disorders in which gain or the loss of an entire chromosome or a chromosome segment has been reported. So gain or loss of the whole chromosome or just its parts, it's a chromosome disorder. Not lymphatocysts that were aborted spontaneously or involve relatively short chromosome segments. Okay, why in the previous slide we had the clinical identifications when we performed the genetic study. One of the identification is the spontaneous abortion, because the spontaneous abortion fetuses are usually the carriers of autosomal disorders. We have three well-defined non-mosaic chromosome disorders compatible with postnatal survival. Three, the most common ones that are viable. Okay, these are autosomal trisomies, very famous ones. I've mentioned one of them many, many times. First one would be trisomy of the 21st chromosome, giving us the Down syndrome. Then the trisomy of the 18th chromosome, giving us the adverse syndrome. And finally, trisomy of the 13th chromosome, giving us the Patau syndrome. So Down syndrome is the first, one of the first, not, it's actually the first reason for the mental disability out of the genetic disorders. Okay. And other than the trisomies, we've got deletion syndrome, which is Cri-du-Chat syndrome or Mewing-Cat syndrome. This is the partial deletion of the short arm P petite of the chromosome 5. Okay, so 5p is deleted, and we've got Cri-du-Chat syndrome, and we're going to discuss all of this four and others more. Okay, so all these autosomal disorders, trisomies, Downs, Patau, Edwards, they have the common features, which is the growth retardation, mental retardation, and the multiple congenital anomalies that are present at birth, detectable, observable, and recognizable abnormalities. Okay. Well, let's start with the Down syndrome, trisomy of the 21st chromosome. Why I've got here pregnant women? Because the Down syndrome is usually linked with the maternal age. Okay, as the mother's age increases, the chance of having a Down syndrome baby is increasing correspondingly. Okay, so 95, the majority of all the affected persons have the trisomy of the 21st chromosome. It means the karyotype is not 46, but as the normal should be, but they have extra chromosome. It means plus one. They've got 47 chromosomes and trisomy of the 21st. But in 95% of the cases, that's the reason of the Down syndrome. It means we've got still 5% that the different reasons could be the cause of the Down syndrome, and we'll discuss each of them. Okay, so meiotic non-disjunction is one of the reasons having extra 21. Okay, so I would like you to remember the division, cell division, meiosis. So the chromosomes, like so. I have nothing to compare to, just my fingers. So these are the sister chromatids, like okay, they are like this. They are sister chromatids. The chromosome is made of two sister chromatids. Okay, let me do like this. Well, they are connected to each other at the centromere part, where the kinetochores are usually the mitotic fibers of spindle fibers, so-called, attached to the sister chromosomes, and just separate them, and the half of them goes to the one cell and the other half goes to the one cell. Okay, so as a result of them, we've got the cell division, and genetic material is divided between the cells as well. So if there is a meiotic non-disjunction, it means that spindle fiber cannot be attached to any of the chromosomes. It just goes to one cell. Okay, you understand? So it means the one cell has more than the one chromosome, the other it lacks. Okay, so usually the trisomy is during this non-disjunction, not separation of the chromosomes equally. So if we have a chromosome count 21st one at 3 times, it means in 95% it gives us the Down syndrome. Okay, so it's the reason of the Down syndrome. Parents of the such children are normal in all respects. Okay, they are just so the parents could be normal but still have a chance to have a baby with them Down syndrome. Okay, and it happens usually once in 1,550 birth in a woman younger than 20 years. It means that one in more than 1,550 cases, but this number dramatically increases when the age of the mother increases. So it happens once in a 25 live birth in a woman older than 45 years. Okay, it means just fivefold or tenfold increase more than yeah, actually it's increasing. So 1 out of 25 women older than 45 could give birth to the Down syndrome in baby. Okay, the maternal origin is confirmed. Maternal meiotic non-destruction or misaggregation of the chromosomes that leads to the Down syndrome. And what are the rest of the percentage that give this rest of 5? Out of 5, in 4%, they have extra chromosome. Could be because of translocation of the long arm of the 21st chromosome to the 22 and 14. That is the Robertsonian translocation. And the translocated chromosome is inherited from one of the parents who is the carrier of this Robertsonian translocation. And 1% of the patients with the trisomy out of this is usually with the trisomy of 20 out of the 95%, they are mosaics. Okay, they have a mixture of the 46 and 47 chromosome cells. Okay, so what are the diagnostic clinical features of the Down syndrome? They've got flat facial profile, they have oblique palpebral fissures and epicanthic folds. Congenital heart disease are very common, like the defects of the endocardial occlusion, atrioseptal defects, atrioventricular valve malformation, and others that are usually the cause of death of these types of the babies and the children and adults. Usually, the lethal outcome is due to their congenital heart defects, if not diagnosed and treated properly. Okay, and also their immune system is very fragile, and they often get the pneumonias and respiratory infections and so on and so forth. Atresia of the esophagus and the small bowel could be increased risk of developing acute leukemia is high with the Down syndrome babies. They're older than the age of 40, develop neuropathologic changes that are characteristic to Alzheimer's disease. So dementia is, if they survive their adulthood, they are at high risk of dementia because of the Alzheimer's disease, and abnormal immune responses that predispose them to the serious infection. That also the complications could be also the reason of the lethal outcome. Okay, now I said the reason is true. In 95% we've got the trisomy of the 21st, but which is the most common, the best known of the chromosome disorders, and is the single most common genetic cause of the moderate mental retardation. And second place is for Fragile X syndrome. Okay, the first one goes to Down syndrome, and yeah, here I said that a trisomy 1 in 800 cases with bone syndrome. It means 95 out of 1,500 is like approximately like this. And along live born children or fetuses of the mother 35 years of age or older, the incidence rate is far higher. So this is the diagram that shows the maternal as the maternal age increases, as the rate of the incidence of the frequency of the Down syndrome as well increases. Okay, so was first described by the Langton Don in 19th century on this child, and increased maternal age and a peculiar distribution within families was also noted by him. And concordance in monozygotic twins, it means if one of the kids, one of the twins monozygotic one had, the other definitely got it. Okay, so almost complete discordance in dizygotic twins and other family members, because dizygotic twins are nothing more just the siblings born at the same time. Okay, So yeah. Uh, Now let's talk about the phenotype of the Down syndrome. It's diagnosed at birth, and shortly after its dysmorphic features develop. Hypotonia is the first abnormality that is noticed in the loss of the tonus newborns. It's dysmorphic facial features, which I have described in the first slide. They have a short stature. The brachycephaly, the occipital bone is flat with a flat occipit. Neck is short with a loose skin on the nape, and the skin wrinkles are the ones that help to diagnose the disease intrauterинally during the phase where the baby's fetus is still in the uterine. Okay, nasal bridge is flat, and the ears are low set and usually full folded appearance. Eyes have brush-filled spots around the margins of the irises, and mouth is usually open with protruding tongue, and epicantic folds and slanting probora features give the rise to the term that is called Mongolic. So Mongolic facial features are what's how the Down syndrome is defined, but we're not using it in nowadays. Okay, and one of this, it's actually um, a single palmar crease. It's not actually just for Down syndrome, but it's also common for the other congenital disorders as well. But their hands are very distinguishable. They're short and broad with a single transverse palmar crease that is called simian crease. And the simian crease is also one of the congenital features of the genetic disease. Okay, and in curved fifth finger, or the clinodactylus, okay, called dermatogryphics, is a pattern of their ridged skin and are highly characteristic. The feet too show a wide gap between the first and the second toe, which I haven't a picture of, and with a few extending proximately on the plantar surface. Okay, and the mental retardation, of course, is the one of the um, parent phenotypic expressions. In early infancy, the child may not seem delayed in the development, but delay usually shows up in the end of the at the end of the first year, where they are usually falling off the course of development, and they comparing to the kids that with the same age, they show the retardation quite apparent. So the intelligence IQ is like between 30 and 60 when the child is as old to um, confirm this, to be tested at all on the IQ, to measure the IQ. So they develop a happy, responsive, and self-reliant persons in spite of these limitations, if thankfully they're in a society that considers them just the rightful parts of the associum. Okay, if they're born into a family that gives them love, cherishes them, and grows up to be part of the family, to be part of the associum, they quite uh, adapt to the environment, and some of them become even famous. Okay, we've got in Georgia, we have many famous like they become actors or singers or painters. They are good with arts, I mean. Okay, in spite of their retardation, of course, but they are very kind and always smiling. All the pictures I've had with the smiling ones. Okay, so so congenital heart defects means that one out of the three Down syndrome, yeah, is got it, and usually are the cause of the death because they are very serious. They have high proportion of borders with the syndrome. It means that even the lateral like abortion could be because of this congenital non-vitable and not compatible with life. Malformations in duodenal atresia, esophageal atresia, tracheoesophageal fistula also common. High degree of permeability in the phenotype is, it means one case could be more severe, the other could be light with just the mental retardation, the other could have all the difficulties and so on. Specific abnormalities are detected in almost all of the patients, okay? And others are only in the subset cases. Okay. So, as I said, half of all abnormalities are identified prenatally. It means before the babies are born intrauterine. It's really easy to detect. Just well, ultrasonography to see the folds of the neck, to count them. Every ultrasonographic knows that. And also to confirm diagnosis, they do amniocentesis, just take the samples by amniocentesis, and they just test the chromosomes and they see extra 21st and give the final diagnosis and the choices after the period. In amniocentesis and in chorionic villus sampling at different maternal age can provide a basis for estimating the amount of the fetal loss between actually can define the diagnosis and the reason for the spontaneous abortion if it is. Additional loss later in pregnancy also could be detected with the amniocentesis. Okay. So, 1 of 4 of the live birth infants with heart defects die before their birthday, so before they even reach a 1 year old of age, and 15-fold increase in the risk of leukemia. And if they pass the 40s, they have the high chance of developing Alzheimer's disease, dementia, and cortical atrophy, and other neurologic deficits, neuropathologic characteristics. Okay. Now I said, get back to the reasons of the Down syndrome. Trisomy of the 21st chromosome is the reason for the Down syndrome in 95%. But also we've got Robertsonian translocation, we've got 21q translocation, mosaic Down syndrome, and partial trisomy of the 21st chromosome. All these make up the 5% that is left out of 95. Okay, this is the trisomy of the 21st chromosome. 95 for patients due through the meiotic disjunction or misaggregation of the chromosomes during maternal meiosis. It happens, and that's why it's linked with maternal age. And 90 of the cases are predominantly meiosis 1, 10% meiosis 2. In paternal meiosis 2, usually. So 90 meiosis 1 in maternal case, 10% meiosis 2 in paternal meiosis. And here we have 3%, maybe less, patients have the Robertsonian translocation. It means that 21q, it means the long arm of 21 chromosome is translocated on the 14th chromosome, or 22 is the Robertsonian translocation. It has no relationship to the maternal age and maternal meiosis, and it has high recurrence risk in families with a parent, especially the mother, is the carrier of this translocation, so it could be inherited. And the other reason, like 1%, is the 21q21 case. It means the 21 chromosome only has the long arms. It doesn't have PR or short arms. So recurrence risk is very low. And mosaic Down syndrome is even rare. I think 2% is exaggeration here. 1% of the Down syndrome is with the mosaic. It means the phenotype may be milder than the others with the trisomies, and wide variability in the phenotypes. That is because of the different reasons that Down syndrome is caused by. Okay. And last one is the partial trisomy of the 21st chromosome, which is really, really rare case. It means not the whole chromosome is triplicated, but we've got the just a part of the 21st chromosome given in 3 copies. So only part of the long arm of the chromosome is present in triplicate, and patients with no cytogenetic visible chromosome abnormalities is even more rarely identified. Okay. Now let's talk about adverse syndrome, and then we can have a break, or can we have a break now? No, we have so many things ahead of us. Let's finish Edwards and then have a break, okay? So, it's rarer than the Down syndrome. Down syndrome was 1,550 cases once if the mother is 20, and 125 if the mother is um, more than 45, and 1 in 5,000 we've got Edwards syndrome. So it's the trisomy. So we've got 18 chromosome triplication, and the patients usually have small head, they have small jaw, it is called micrognathia, small chin micrognathia, clenched fist with overlapping fingers, like you see on this picture. They have this plastic ears with a malformed shape. They have severe intellectual disability, and the form of the skull that is very prominent with the adverse syndrome. They have short shield chest, and they have fixed big toe, prominent heels, and a small neck, a small chin, as you can see, and a small neck as well. They have kidney malformation, structural heart defects, and like Down syndrome. They all usually the intestine protrude outside of the body. That is called omphalocele. Congenital hernias, esophageal trace intellectual disability, obviously, developmental delay, growth deficiency, feeding difficulties because of the anatomy, and they usually nasogastral tube feeding, and breathing difficulties, and arthrogryposis, which is contractures in the joints, which makes unable to move the limbs. And the microcephalus means they have small brain with the different small shape of the head. They have low set, malformed ears, micrognathia, that is the small chin and jaw, mandible, and then cleft lips and cleft palate. That is the reason for the malnutrition and poor respiration and the poor feeding. Turned nose and narrow eyelid folds. Hypertolerance, it means their eyes are located distant from each other and from the nasal bridge. Hypertolerance, away, and if they're close, they're called hypertolerance. Okay. Blepharoptosis, it means they're just like eyelids are the fall down. It's not possible to open the eyes fully, just like me, because I'm half asleep now. And I had 2 lectures, and I had the night shift, was quite terrible. Short breath, bones, clenched hands, and these ones I have already listed. And okay, now we can have a rest and go on with the towels and rest. Okay. Do you have any questions still here? Any questions? Can I know what are the topics will be included? Okay, I'm not Meta you Puja, though I've talked in the beginning. I will simply repeat myself. We have week 7, week 7, including week 12, okay? We've got the syllabus. If you don't have, just mail me and I will send it to you. Starting from the week 7, including the week 12 material, will be the midterms material. Okay. Okay. See you in 10 minutes. You're welcome. Anytime. Okay, guys, welcome back. Mm, let's go on with the Patel syndrome. So this is one of the other reason for the mental retardation, and the trisomy of the 13th chromosome. It's usually includes the nervous system, including intellectual disability, motor disorder, microcephaly, eye defect, retinal dysplasia, blindness, and so on and so forth. They have small head with a flat occiput. They have absent eyebrows, the cleft lip and cleft palate that requires the how to say emergency surgery. Otherwise, they are not able to feed, and they um, of course, the respiratory dysfunction is also possible. They have dysmorphic and malformed ears, and also they have clenched hands and extra finger. And here, polydactyly, it is called. The poly means many, digits are the dactylis, and polydactyly, it means the extra finger. And undescended or abnormal testis is really often. Musculoskeletal and cutaneous form with polydactyly, low set ears, prominent heels, omphalocele, and overlapping fingers over thumb, cutis aplasia, cleft palate, and these are all the features of the Patel syndrome. And urogenital ones include abnormal genitalia, kidney defect, heart defects include ventricular septal defect, patent ductus arteriosus. What does it mean? Ductus arteriosus is the duct that connects the arterial and venous blood flow in the newborns. Okay, when the newborn blood circulation is dependent on the mother's, so placental circulation, but after the baby is born, there is no such need because it has its own, he or she has its own uh, has her own blood circulation. So ductus arteriosus usually obliterates. It means it's just closed up over time. But if it stays open, it means there is a constant blood flow between arterial and venous phase, so they keep the pulmonary hypertension, and the babies usually die without the surgery. They need to mechanically surgically close this ductus arteriosus. So this is one of the reasons. Dextrocardia means the heart is not facing the left, the apex of the heart, but looking at the right side. Dexter is right, sinister is the left, and the single umbilical artery. The fetus has two umbilical arteries in one vein, and if in case of one artery there is lack of the insufficiency with the blood flow. And the last one is the Kritochvil syndrome. So it is not the trisomy, but the reason is the deletion of the long arm of the fifth chromosome. It's a terminal testral deletion part of the not the long, but the short P arm of the chromosome 5. And why it's called Kritochvil? Kritochvil is the because the babies cry like a mewing cat, and that's why it's called like this. It's the crying infants with the disorder sound like mewing cat, and 1% of institutionalized mentally retarded patients. Institutionalized, it means the mental retardation is thought to be the psychological ones, but 1% is the carrier of the Kritochvil syndrome. The microcephaly means small brain, hyperintelligence, and epicantic faults are yellow set ears, sometimes prairie color tags, and micrognathia. Micrognathia small gene is the characteristic features of the Kritochvil syndrome. Okay. Other than this four, we've got DiGeorge syndrome, like it's a deletion syndrome, but deletion happens on the 22nd chromosome in the long arm, and this is the locus 11.2. Locus is deleted. Yeah, and congenital heart defects and so on. Also, most common in T cell immunodeficiency and hypocalcemia are very, very dominant features of this disease. And usually, the patients don't reach even the year; they just die early. Okay, usually, and at the same Point deletion can give us the velocardiofacial syndrome. This is the mild immunodeficiency and with pronounced dysmorphology and cardiac defects, and they've got high risk for schizophrenia and a bipolar disorder. Okay, the diagnosis made all of this genetic disease could be diagnosed by using the fluorescence in situ hybridization, which we discussed in the last fish. Okay. Uh, and Klinefelter. So these were all autosomic disease, right? Cancer um, linked with the autosomal chromosomes. Now let's talk about the sex chromosomes and disorders which are linked with this X and Y chromosomes. The first disorder is the Klinefelter syndrome. It's a male hypogonadism that develops when there are at least two X chromosomes. It means male, but with two X chromosomes, and one or more Y chromosomes. So karyotype, they are hypogonadism, mean males. They males in phenotypically, but the genotypes consist of at least two X chromosomes. So it looks like 47, one extra chromosome, one extra X. So XXY is the karyotype of the Klinefelter syndrome. Okay. Distinctive body habitus with an increase in the length between the soles and the pubic bone and the elongated body that is called eunuchoid body habitus. The ones, yes, you know what eunuchs means, and reduced facial body and the pubic hair. And gynecomastia is the breath, growing breath in the males. Okay. Testicular atrophy, the serum testosterone levels are low and they're normal, and the urinary gonadotropin levels are elevated. Mental retardation is one of the features, high frequency of the breast cancer in the males, and autoimmune disease like the systemic lupus erythematosus are very common. Turner syndrome, it's the primary hypogonadism in the phenotypic female. So in phenotypic males, it was Klinefelter. In females, it's the Turner syndrome. But instead of the two X and Y, we've got the monosomy of the short end of the X. It means we have lack, or the whole X could be missing. Monosomy, it means having one X chromosome. So instead of 46, we've got 45 chromosomes and X1X, or the variants could be just a small part of X, for example. Growth retardation, abnormally short stature, is a clinical feature of the Turner syndrome, and swelling of the nape of the neck because of the distended lymphatic channels in infancy that gives a webbing of the neck in the older children. So wide the neck, like distorted, webbed neck, so called. Okay. And uh, they have low posterior hairline, the cubitus valgus, increase in the angle of the arms, shield-like chest, widely spaced nipples, a high arched palate, lymphedema of the hands and the feet, swollen, congenital the malformation like horseshoe kidney, or bicuspid aortic valve, or coarctation of aorta with the Turner syndrome. Cardiovascular abnormalities are the most common reason of the lethal outcome during the childhood. And primary amenorrhea, it means they don't have the menstrual cycle at all. Okay, they are females phenotypically, but they only have one X chromosome. Along with the mental retardations, they've got the clinical hypothyroidism also present. Okay, now disorders of the gonadal and sexual development include hermaphroditism. Oh, I'm not sure how it's pronounced. Hermaphroditism. So it means they're having both ovarian and testicular tissues present, but one of them is more developed, the other is less, but still both of them are present. And the patient can actually choose which gender he or she belongs to. And so gonadal dysgenesis and optomelic dysplasia that is due to mutation of the SOX gene, the chromosome 17 is autosomal dominant disorder with usually lethal skeletal malformations. Okay, and this is the chromosomally male patients with the ambiguous external genitalia are called syndrome, Dennis-Dresch syndrome, and the patients with one more severe Frazier syndrome show XY complete gonadal dysgenesis. Frazier syndrome, XY dysgenesis. Okay, so let's talk about first female pseudo hermaphroditism and the male, the next one. So they have gonadal tissue of only one sex that matches their chromosomal constitution. It means if they have two eggs, they have gonadal tissue of the female. If they have X and Y, they have male gonadal tissue. But the karyotype is actually 46XX. Okay, well, that's why it's called female from pseudohemor. So the karyotypically they're females, but they have gonadal tissue of the female, but still with they are present with the male external external how to say, with a normal variant tissue, but within ambiguous or the male external genitalia. Okay, this is congenital adrenal hyperplasia could be the reason of that. Defects in the enzymes of adrenal cortex required for cortisol synthesis are resulting in the virilization of the female infants. Is having a hair at the parts that were they are not supposed to, and so on and so forth. And about the male hermaphroditism, the karyotype will be normal males like X46XY, and also, but they have disorder of the testa formation during embryological development, and within completely masculinized or female external body parts, for the genitalias, and abnormalities of the gonadotropins, inherited disorders of the testosterone biosynthesis and metabolism could be the reason of that, and abnormalities of the androgen target cells. Okay, and the X-linked syndrome, there is no androgen insensitivity syndrome or testicular feminization. That is also how it's called. Okay, the X-linked one. In spite of the genetically they're males, they look like females. So now that was all about the gender disorder. Now let's talk about the single gene disorders with atypical patterns of inheritance, like disease that caused by triplet repeat mutations, for example. So it means that three nucleotide sequences that repeat and they increase their frequencies. Like this is caused by mutation in the mitochondria genes. Also, don't follow the common pattern of inheritance because the mitochondrial genome only can be inherited through the maternal inheritance because it is transferred to the oocyte, not to via the spermatocyte. Spermatocytes do also contain mitochondrial genome, but they get deactivated and degraded. Only oocytes can descend their material to the next generation. This is associated with alteration of the important regions of the genome and the others, like like the complex disease, which we can discuss next. Okay. So now let's talk about the Fragile X syndrome. It's due to the nucleotide repeat syndrome. It's a causative mutation. Causative mutation occurs in a long repeating sequence of the three nucleotides, and like the other diseases like Huntington's disease, myotonic dystrophies, cerebrospinal atrophies, and other dyskinesias. Also, the reason for this disease is the three nucleotide or triplet expansions. Okay, so associated with the neurodegenerative changes, it happens once in one. It's like the Down syndrome for males, and for females, it's less frequent. It's autism-like symptoms and long face with large mandible, with large averted ears, and large testicles, microorchids, is the clinical features of the Fragile X syndrome. It is the second reason for the male mental retardation after the Down syndrome. The carriers are affected, carrier males affected females also. Anticipation and clinical features affects Fragile X syndrome worsen with each successive generation. Why? Because usually the nucleotide triplets, this uh, their frequency expands within each cell division. So within every generation, the frequencies are expanding, and it is linked with more severe form of the disease and earlier onset of the disease. Okay. So the tremor, fragile X tremor ataxia, is another disease not linked with the mental retardation, but the ataxia, like the Huntington's disease, dysphoria, tetosis, and so on and so forth. Okay, and mitochondrial genes are usually maternal inheritance because all sites are able to transfer it. Mitochondrial DNA of the zygote is derived entirely from the ovum, and mothers transmit mitochondrial genes to their offspring, both males and both females. Affect organs most developed under oxidative phosphorylation, ATP, CNS, skeletal muscles, cardiac muscles, liver and kidney disease. And one of the common disease caused by mutations in the mitochondrial genome is the Leber hereditary optic neuropathy. It's a neurodegenerative disease, manifests as progressive bilateral loss of the central vision. The periphery is so they just like looking in the loop, they lose the central focus that leads to due to the cause of the blindness. Okay. And Prader-Willi syndrome, functional differences exist between the paternal and the maternal copies of the some genes. Like Prader-Willi deletion of the paternal chromosome, it causes mental retardation, short stature, hypotonia, obesity, small hands and feet, and hypogonadism. And that is not like the mitochondrial one, which is linked with maternal. This one is linked with paternal inheritance. And the last one is Angelman syndrome, which is deletion of the maternal chromosome region and the chromosome Q. It means the shifting chromosome of the Q arm, it means the long arm. And the patients are usually mentally retarded, they've got ataxic gait, they have seizures, and appropriate laugh rate, and that's why this disease is called happy puppet syndrome. Okay, Angelman syndrome, happy puppet syndrome. Okay, so these slides I will leave you with, and be back in 5 minutes. Meanwhile, you read this part. Or okay, I think I will better continue because we have one more PPT. I'm already tired, but I know you're tired too. So okay, so the term mutation refers to the permanent change in the DNA, which is usually inherited. And those that affect the germ cells are transmitted to the progeny and may give rise to the inherited disease. But those that appear to the somatic cell, they are usually not inherited, but they appear to be the reason of the pathologies in the very individual that they appear. Okay. Point mutations result from the substitution of the single nucleotide base by the different base, resulting in the replacement of the one amino acid by another in the protein product. So the example of this is the sickle cell anemia. So instead of the DUC, we've got GAC. So one single nucleotide change that will change the whole codon, the codon that specifies the special amino acid. And instead of one amino acid, we've got the other glutamate is changed with the valine at the sixth position, and entire polypeptide product change. So instead of the hemoglobin, which should be hemoglobin A, that gives like the donut shape to the erythrocytes, which are mobile, elastic, and they can easily squeeze through those small vessels. The sickle cell, during the sickle cell anemia, the hemoglobin S is the synthesized, which gives the sickle shape to the erythrocytes instead of the donut shape. And this sickle shaped erythrocytes, it means they acquire the new feature, but this new feature is not always beneficial. It's this sickle shaped erythrocyte, they lack the elasticity and they cannot squeeze in within the small vessels. They get jammed in the vessel, they cause the vasocongestion, occlusion of the vessels, and they just break down, they cause the hemolysis and anemia due to all this. Okay, so it means a one nucleotide point mutation give rise to this be much of a big and sometimes even lethal pathology. We've got nonsense mutations. It means that we've got interrupt translation. So it means the termination of the transcription before the RNA is finished, and it leads to the translation, the formation of the proteins that are unfolded correctly or are non-functioning proteins. And we've got frame shift mutation. It means if we delete one of the nucleotide or insert one of them, it means the reading frame changes. So instead of CUG, for example, we've got the reading frame shifting, and instead of one codon that specifies one amino acid, they will specify the other, and also the amino acid sequences will change. Okay, we've got clinical repeat mutations, which is a special category. They're characterized by amplification of the sequences of the three nucleotides, and the disease or like Huntington's disorder, like disease like a Fragile syndrome, those are cerebrospinal ataxias. These are due to three nucleotide repeat mutations, okay, and expansions of them. Amplification or deletion or translocation, they result in aberrant gain or the loss of the function. Okay, so deletion means the loss of the function, translocation or insertion or a duplication, which is the reason of amplification, which is the gain of the function. But sometimes, as I said in the beginning, loss of the function is more severe than the gain of the function. The Mendelian disorder resulting from mutations in the single genes, and they follow the inheritance rules. They are either autosomal recessive, autosomal dominant, X-linked recessive, or X-linked dominant. Okay. So complex disorders involve multiple genes. Complex disorders that are called common gene disorders. It means they are not just linked with genetics, but they are epigenetic factors like the environment, external signals, and chemicals, and like this. So these are called complex disorders that don't follow the rules of common, like Mendelian disorders. Okay, for single gene disorder. Disease arising from chromosomal abnormalities, including changes in the number of the structure of the chromosomes. So that's why their chromosomal abnormalities could be numerical and structural as well. So Mendelian disorders that are caused by the single gene mutation, they are very rare. Together account approximately 1% of the adult admissions and 6 to 8% in the pediatric admissions. But it does not give us the reason to think that they are solely pediatric age. Okay, and they follow four rules of inheritance: the autosomal dominant, either autosomal recessive, X-linked dominant, or X-linked recessive. And the single mutation may have many phenotypic effects. It means the same mutation can cause the different clinical features. Like in Down syndrome, we have different phenotypes, right? So they are pleiotropy, so-called, having a different phenotypes, and mutations at the several genetic loci may produce the same trait. It means they have genetic heterogeneity. Yeah. And let's now talk about the autosomal dominant inheritance. Dominant means autosomal means their mutation is located on autosomal chromosome. Dominant, it means that one mutated allele is enough for the disease to manifest. Okay, so the disease is manifested in heterozygotes as well as in monozygotes. So it means this carrier is manifesting. Okay, so they manifested in the heterozygous stage. So at least one parent in an index cause case usually is affected, and both males and females can be affected. So there's a gender difference when we're talking about the autosomal dominant disease. They can and both sexes are able to transmit the condition to their offsprings. As you can see, in this case, father is a carrier, mother is a healthy one, but still 50% of the offsprings are the diseased one because they got the disease L from the father. 50% are healthy, 50 are diseased. With any autosomal dominant disorder, some patients do not have affected parents. And how it happens? Because of the clinical features can be modified by reduced penetrance and variable expressivity. So what is the reduced penetrance? It is some persons inherit the mutant gene but are phenotypically normal. So in any other case, they should be abnormal, but they are normal because then we are saying that this phenomenon is referred as the reduced penetrance. Okay, but if a trait is consistently associated with a mutant gene, but is expressed differently along persons carrying the gene, the phenomenon is called variable expressivity. So one trait associated with the mutant gene, but expressed differently among the carriers, it's called variable expressivity. In many conditions, the age of the onset is delayed, and the symptoms of the origins or signs do not reappear until the adulthood. Okay, so in autosomal dominant disorders, 50% reduction is the normal gene product is associated with the clinical signs and the symptoms, and the presence of mutated collagen chains reduces the assembly of the remaining normal chains, producing a marked deficiency of the collagen. In these instances, dominant negative. Okay, just forget it. Now let's talk about autosomal recessive. Again, the mutation is in autosomal chromosome, but in case recessive, meaning that the only homozygous to this disease can be the manifests. Okay, because one disease allele is not enough for the disease to be expressed. It takes both of the affected alleles in order for the manifest to take to phenotypically expressed. Okay, so you see the carriers here. It means both of the parents are the carriers here, but none of them is disease. They don't have the expression of the disease, but just the carry disease allele. But the one out of their child, it means uh, 25% of their offspring is diseased, 50% is the carrier just like the parents, and 25% is healthy. So it means 1/4 is disease, 1/4 is healthy, and 1 and 2 is it means 50% is carrier. Okay, the autosomal recessive disease is manifested in homozygous state, so it's never manifesting in heterozygous state. They occur when both of the alleles are at the given gene locus are mutants, and the trait does not usually affect the parents who are the carriers of one diseased allele, but the multiple siblings may show the disease. Siblings have one chance out of 4 to be affected. Okay, 25%. The expression of the defect tends to be more uniform than in autosomal dominant disorders. Complete penetrance is common. It means complete penetrance. It means when both of the mutant alleles meet each other, definitely the disease definitely shows itself. Onset is frequently early in the life, and also new mutations for recessive disorders do occur. They are very rarely detected clinically. In many cases, enzymes that are affected by mutation. Because if the enzyme deficiency is the dominant, it means if there is any healthy allele, it could be responsible for production of the normal enzyme. But in case of recessive, it takes two mutant alleles. There is no healthy protein produced and no function at all. So that's why enzymes are affected by the recessive disease. Okay. And the last one is the X-linked disorder. It is the heterozygous female carrier that transmit them only to the son. So females are the carriers, and females are able only to give it to the sons, because again they give X to the both of them, but the sons cannot get it from the father because father gives them the Y. Okay. And the sons and the males cannot be said to be heterozygous or homozygous in terms of the X, because they only got one X, and they are called to be hemizygous for with respect to the X chromosome. Heterozygous females rarely express the full phenotypic change because they have the pure normal allele, and an affected male does not transmit it to the sons because it only gives the Y chromosome to the son, but the affected male will surely pass this disease down to their daughters, which will become carriers or will pass on the disease to the other generation. Okay. Now let's talk about some diseases that are caused by mutations in the structural protein coding genes, like the autosomal Marfan syndrome, which is the autosomal dominant disorder of the connective tissue, manifested principally by changes in the skeletal and the eyes, cardiovascular system. It is caused by an inherited defect in an extracellular glycoprotein called fibrillin 1. Mutation in the fibrillin 1 gene. Clinical features include tall stature, long fingers, bilateral subluxation of the lens, valvular prolapse, aortic aneurysm, aortic dissection, which are all lethal. See the scar here? This guy has probably been undergone the surgery because of the heart defect. Okay, and the arms and the legs, which are very, very long and thin here. And this is typical clinical feature. They've got eye probes, they've got bone guards, the fingers, they've got normal chest and heart and lung problems. They've got torso, short torso, but another group of the disease characterized by the defect in the collagen synthesis, and it's the skin fragility is present, skin extraordinarily stretchable, extremely fragile, vulnerable to the trauma, and they've got scoliosis and kyphosis within together, and it's called hyposcoliotic Ehlers-Danlos syndrome. We've got vascular Ehlers-Danlos syndrome, classical ones with the diaphragmatic abnormalities as well. And familiar hypercholesterolemia. This is the autosomal dominant receptor disease that is caused by the loss of the function mutation in the genes encoding the low density lipoproteins, LDL receptor, which is involved in the transport and the metabolism of cholesterol. And mutations in this LDL receptor proteins impair the intracellular transport and catabolism of the LDL, resulting in the accumulation of the low density LDL cholesterol in the plasma that causes cardiovascular problems. The patients are prone to myocardial infarction, coronary disease, and so on and so forth. So remember familial cholesterolemia. So, and yeah. Yeah. The xanthomas. So atherosclerotic plaques form not just in the blood vessels, but they're on the skin and the joints as well, and they're called xanthomas, cholesterol deposits along the tendon sheets that produce the xanthomas. Okay, and cystic fibrosis. Okay, I will leave with the slides, and I will be back at 7. You meanwhile you read the slides, okay? Okay. Okay, welcome back. I hope you were reading and relaxing. No, I'm not. I wasn't explaining. I just left you with the slides, and I am coming back with the new one. Okay, so this one is yeah, yeah. This one is not included in the second midterm, but it's for sure gonna be the part of the final. So okay, let's get started. Again, it is from Thompson and Thompson, chapter 7. We're going to talk about the genotype, phenotype. We're going to talk about the pedigrees, Mendelian inheritance, factors that affect the pedigree patterns. What is the pedigree itself? And we're going to define the genotype and phenotype. And we're going to talk about the autosomal patterns as well as X-linked ones. Okay, so let's go on. So, what are the types of genetic disease? We listed that in a previous PPT. They could be the single gene due to the single gene mutation or single point nucleotide substitutions. It could be chromosomal due to numerical or structural changes in the chromosomes, and could be complex ones that are not just defined with genetics, but also environmental factors that have the influence on the development of this common disease, okay, complex disease. Single gene traits caused by the mutations in the genes of the nuclear genome that are often called Mendelian because their characteristics, like the Garden peas, which were studied by the Greek and Mendel, and they follow the rules of Mendelian inheritance, which is autosomal dominant, autosomal recessive, X-linked dominant, or either X-linked recessive. The four ways of inheritance for the Mendelian inheritance. But there are chromosomal disorders like which include entire chromosome, like, or it could be just the parts of the chromosomes, could be missing in case of deletions, could be duplicated, or could be altered device like during translocations and so forth. And the example of this include Down syndrome, trisomy of the 24th, Turner syndrome, monosomy of the 15th chromosome, and also so-called single gene chromosome, single gene disorders or Mendelian conditions, which are caused by the single gene alteration. For example, like in cystic fibrosis or in sickle cell anemia, I said that one single codon is altered, one amino acid is changed, and that leads to the pathology. And during hemophilia as well. And we have complex disease, so-called multifactorial disorders, which result not just for the due to the genetic disorder, but also epigenetic factors like environmental causes, chemical, other mutagens affecting the development of the disease, like the birth defects, cleft palate, cleft lip, like many adult disorders, like even hypertension, arterial hypertension is also multifactorial disorder. It doesn't necessarily mean it is inherited, but it has definitely genetic features because the family history is important, and also epigenetic factors like eating habits, unhealthy lifetime, and so on and so forth. They affect the development of the disease, and as well as the diabetes mellitus, which is also multifactorial, and cancers also I consider to be multifactorial because their development is not inherited, but their chance and the risk is just dramatically increasing when there is a family, the individual with the cancer. So it means the risk can be inherited. And mitochondrial disorders, lastly, which don't fall into any of these listed categories, are the whole entire separate entity, and the relatively small number of the disease that are caused by the alteration in the small cytoplasmic mitochondrial chromosomes. Okay, Let's start with the single gene disorders. They are often considered to be primarily, but no means exclusive disorders of pediatric age because the 10% manifest at the puberty, others at the end of reproductive period. So they are not necessarily pediatric one, but the ones that are detected at birth during the birth. So Mendelian forms are important in individual patients because of their significance for the health of the other family members and because of the availability of the genetic testing and detailed management options for many of this disease. Okay. Now let's discuss the variations in genes. Inherited variations in the genome is a cornerstone of the human and medical genetics. We've got the locus, which is the location of this, so that is the sequence of the DNA that encodes that contains the one gene. Then the segment that contains the gene is called locus, and the alternative variants of the genes are called alleles, located on the different chromosomes, but defining the same features. The other versions of the gene are called the variant or the mutant alleles that differ from the wild type allele, which is the original normal one, because of the presence of the mutation, the inherited change in the chromosome structure, permanent change in the nucleotide sequence, or arrangements of the DNA. Okay, so the given status of the alleles at the locus or the cluster of the loci on a chromosome is referred as the haplotype. Now let's talk about the variations in the genes. So if there are at least two relatively common alleles at the locus in the population, the locus is said to be polymorphic, or we can also refer to it as polymorphous. Poly means many, literally, and morphous means form. So it has many forms. It means more than one form. So, and the term mutation is used to define two things: the process by which mutation occurs and the change itself. Okay, the term mutation is used in medical genetics in two senses: sometimes to indicate the new genetic change that has not been previously known in a family, and sometimes to indicate the disease causing mutant allele itself. Mutation and mutant are never ever used to refer to the human being who carry the mutated alleles. That is very offensive and not cool. So let's talk about the genotype and the phenotype. So genotype of a person is the set of alleles that make up his or her genetic constitution, either collectively at the all loci or typically at a single locus. So in other words, genotype is the genetic makeup of an individual, while the phenotype is an observable, detectable expression of the genotype. It could be in terms of morphological changes, clinical changes, cellular expression, or a biochemical trait. It doesn't necessarily mean to be observed by the BIs, but could be the changes in the blood count, laboratory changes. These also count as the phenotype. Okay, so phenotype is usually thought of as in the presence or the absence of the disease, manifestation of the genotype. So any expression of the genotype is called a phenotype. Okay, could be referred to as a manifestation of the clinical features, included characteristics can be tested only by blood or by tissue testing or by morphological observations. Okay, a phenotype, of course, be either normal or could be abnormal depending on the given individual, obviously. So, abnormal phenotypes are called genetic disorders, caused by the genetic disorders. Also, one gene usually encodes a polypeptide chain of the RNA molecule. A single abnormal gene or the gene pair often produce multiple diverse phenotypic actions, and it is called the pleiotropy. Pleo means many forms, like poly. So pleiotropy means that the expression of the gene can be variable, pleiotropy. And also, Homozygous and heterozygous. What is the definition? Homozygous means it's identical alleles encoded, identical alleles, but the alleles are different. He or she is said to be heterozygous. Like the alleles for defining the eye color, the one defining blue eyes are come from the blue eyes. They are called to be homozygous, defining the same expression of the same feature in a different ways is called heterozygous. In the same way, it's called homozygous. Okay. So the term compound heterozygous, though, is used to describe the genotype in which two different mutant alleles of the same gene are present. It means two mutated, but the different mutated alleles is called compound heterozygous, and there are the one normal and one mutant. Compound is in terms of the diseased mutated allele. Okay. So the heterozygous or homozygous can never be referred to the sex chromosome, especially to the male sex chromosome, because they only got one X, the other Y, so they are neither heterozygous or no homozygous. They are called to be hemizygous in terms of the sex chromosome. So they referred hemizygous male in case of the X chromosome disorder. And what about mitochondrial genome? As I said, it's neither autosomal, neither dominant, neither recessive, neither X-linked. It's an entire different branch, different thing, and it has its own rules, which we gonna see further. Okay, so now let's talk about the pedigrees. What is the pedigree? Pedigree, in other words, it's the map of the family. Okay, the family tree. So single gene disorders can characterize the patterns of the transmission of families. So, in other words, it's a graphical representation of the family tree. It's called the pedigree. So, when we are talking about the family on the pedigree, we are referring to the kindred, not the kingdom, but the kindred is called the family. And the proband is the one that is the carrier of the disease, but the proband is not necessarily the one that came for us for consultation. For the person who came for us to make up the pedigree of the kindred is the consultant. Okay, consultant is not necessarily to be a proband, but to be just the family member of the proband. Okay, so consultant doesn't necessarily mean an carrier of mutation or proband. Okay, could be a sibling of the proband, but the siblings, brothers and sisters are called sibs in the kindred, and their first degree relatives, second degree relatives. First degree include parents, sisters and brothers, offsprings of this proband. Second degree are grandparents and grandchildren, aunts and nieces, and nephews and uncles. And the third degree include first cousin, second cousin, and so on and so forth, according to the family tree. Yes. And now the couples who have one or more ancestors in common, they are called to be consanguineous, sharing more than one ancestor or one or more ancestors. They're called to be consanguineous. Okay, consanguinity is the reason of the many autosomal recessive disease to be expressed in a small population, like in the Ashkenazi Jews. Tay-Sachs disease. It's a very rare autosomal recessive disease, which is not very common, but it is very common during the Ashkenazi Jews because they are because of the inbreeding and because of consanguinity. Okay, and we're gonna see that too. If there is only one affected member in the family, he or she is called isolated case. Okay, only one proband, it is isolated case. But if the disease is due to new mutation, so an isolated case, but the reason is not inherited, but the new mutation, we're calling it a sporadic case. Okay, sporadic, it's one and all. So, okay. So now let's talk about the other features of the pedigrees, like the fitness. Fitness is not the one what you think. It is the reproductive ability of the diseased one, of the one care of the problem. Okay, so it's the measure of the impact of the condition on a reproduction. So it's a reproductive success of the genotype, usually measured as the number of the offspring produced by the individual that survive the reproductive age relative to the average of the population. Okay, it's not linked with the mental or physical ability. Like I will give you an example, you will understand. Like in case of the Alzheimer's disease, like the one this the one of the most common reasons for the mental the senile dementia. So fitness is 100%. It means they have got 100% the ability to reproduce and give the offspring. Why? Because their reproductive ability is not impaired with the disease, because they are well past the reproductive age when the disease starts, like in their 60s, 70s, and 80s. Okay, when they already have children and even grandchildren. So the fitness of the Alzheimer's disease is 100%. But what about like what about the my Friedreich's ataxia, for example, or the Duchenne muscular dystrophy? So this disease onset starts in the in the late childhood, early teens, and they usually don't reach the reproductive age. And if they do, the disease starts from the limb muscles and goes up and up, including the respiratory muscles that they usually die of the cessation of the breathing. They cannot breathe independently, and they are on the mechanical ventilation, and they can die out because of the complications of the long-term ICU treatment. But usually, their mental ability is not is intact. It means they're just the hostages. The brain is the hostage of their body. So the fitness is zero. It doesn't define the mental ability. Okay, and in case of the yeah, Alzheimer's disease, is not affecting the mental ability, their fitness. Okay. Okay, so it's some disorders, an effective individual can be normal, have normal mental capacities and health, but have a zero fitness because their condition interferes with the normal reproduction. In other their cases, severe debilitating genetic disorder may have normal fitness, like Alzheimer's, but because instead of the disease well past the usual reproductive age. Okay. So now let's talk about the phenotype, dominance and recessive. Dominant means that it's expressed in both homozygous and heterozygous. So it means being a carrier is always meaning that you have the disease expression. But in the recessive disease, it means it takes two mutated alleles for the disease to be expressed. So being a carrier is not enough to have the disease. So, but there are exceptions, of course. Dominance is a relative thing. Okay, complete dominance, partial ones, there that's a price. So we've got 22 autosomes, and we've got X and Y sex chromosomes, and the disease are divided into four ways of inheritance, like autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. So autosomal and X-linked, according to the location of the mutation of the on which chromosome, either autosomal or X chromosomes or Y chromosomes. The first autosomal disorder affects males and the females equally, because males and females got equal sets of the autosomes. But X1, it does not affect the females and males equally. Usually females are the carriers because they simply have two X chromosomes, and they are whether the normal one can um, overlap the abnormal one, but the males are usually the diseased ones if the disease linked with the X chromosome, because simply they have one X chromosome, they are hemizygous to the X linked disease. Okay. And yes, this is the dominant inheritance which we have gone through. One disease allele is enough to have this disease, one of parent is always affected, and 50% of the offspring is affected, 50% is healthy. So it means one out of two chance to have the disease. But we have terms like codominance, like we have when we have, according to the ABO group, blood groups, and we've got incomplete dominance or semi-dominant. It means that still we have a heterozygous carrier of the mutant, but the disease is not depressed. It's not in that's a complete dominance. Okay, it's a case of incomplete dominance. And has recessive disease are usually linked with the loss of the function of the enzymes, as I managed to say this far. And usually parents are healthy carriers. It means they carry the normal allele, but they're heterozygous and the disease is not expressed. So the carrier parents have the offsprings of them have 25%. It means one chance out of four to have the disease, and one chance out of four to be healthy, and 50% of the offsprings are usually the carriers, just like their parents. Okay. So the factors that affect the pedigree patterns of the kindred is the penetrance. The penetrance is the probability that a gene will have any phenotypic expression at all. So it will be expressed or not. It is dependent on the penetrance of the disease. And expressivity. Expressivity can be reduced penetrance. It means if the dominant disease is not expressed in heterozygotes, it means it has the reduced penetrance. And also we've got variable expressivity. It means that the severity of expression of the phenotype among individuals, genotypes varies. It causes the different variations of the disease. So variable expressivity could be also the reason of the different expression of the disease. Like this is the pedigree, so the map of the kindred, with the split hand deformity demonstrating failure of penetrance and the mother of the consultant. Consultant is shown in the arrow. So this is the person who came to us for the consultation. This is not a proband. This is not a carrier of the is the carrier of the disease. But you see, the parents are quite, they are healthy. So why they've got this autism? This is from where did he get it? Because parents are healthy, but the grandma, the fault is in grandma. She passed down this disease to two of her daughters, and this one too. This one is a carrier, but this because of reduced penetrance, she doesn't have the expression of the disease, but she's carrier of the dominant disease, so the which he gave to the son. Okay, and here maybe this one is also has a reduced penetrance as well. So reduced penetrance must be taken into account in genetic counseling. So it doesn't mean her offspring won't get the disease. It also she also could have a reduced penetrance. It could be the carrier of the disease. So it is the reason to study her carrier type as well. Okay. So now other factors that affect the pedigree, it's the age of the onset of the disease. It starts prenatally, intrauterine inside the uterus, post-reproductive years, prenatally or congenital. So we should differ two terms, congenital and congenital disease and the genetic disease. Congenital disease are not always genetic, and genetic diseases are not always congenital. Okay, so genetic disorders is the one that is determined and caused by the mutation in the genes, where the congenital disorder is the one that is present at birth. Okay, that may not be because of the genetic basis. So they not definitely because of the genetic disorder. So congenital could be the one that means the present during the at birth, but it's not necessarily genetic. And as well, genetic disease cannot necessarily be congenital, because like Alzheimer's disease, it expresses only in the adulthood and in the senile people. So it's not necessarily to be congenital. You should know this difference between these two terms. So now let's talk about heterogeneity. It means the genetic heterogeneity may be the result of the different mutations at the same locus. That is the example of allelic heterogeneity, and could be mutations in a different loci, like a locus heterogeneity. And we also have clinical or phenotypic heterogeneity. And the examples of these are first, allelic heterogeneity, which is due to different allele mutation, like cystic fibrosis, dozens of different, like more than 1,400 mutations are the cause of the disease and has allelic heterogeneity. And then locus heterogeneity is like in during retinitis pigmentosa, which is the rare degenerative disease, the common cause of visual impairment due to photoreceptor degeneration, has long been known to be occurring in autosomal dominant pathway, autosomal recessive, and X-linked forms because of the location of the different locus heterogeneity. Okay, and phenotypic heterogeneity during Hirschsprung's disease that can be with the different severity, and so phenotypic geneticity is like a variable expressivity. Okay, now let's talk about the gender influence disorders. Like since the males and females both have the same complement of autosomes, usually autosomal disease are met with the same frequency in the males and the females as well, and the severity as well. But there are exceptions sometimes. Some autosomal recessive phenotypes are the gender influence, expressed in both of the sexes but in different frequencies and severities. And some are not influenced by the sex chromosomes. Sex influence itself, the lower incidence of the clinical disorder in females is believed to be related among the furthest to the lower dietary intake of the iron, lower alcohol usage abuse, and increased iron loss during menstruation among the females. So, and then again, gender can also influence the genetic disorders. Now let's talk about the consanguinity. We said that if the couple has more one or more than one common ancestor, they are said to be consanguineous. Okay, they're sharing their ancestors. It's believed that everyone carries at least 8 to 10 mutant alleles, of which perhaps half are lethal to the homozygous before the birth. The remainder cause of well-known, easily recognizable autosomal recessive disorders. But the chance to get this recessive disorder is very rare unless they've got the common receptors, they both are the carriers, they pass these disease to their offspring, and then the chance is increasing much, much. So the consanguinity is defined arbitrarily as the union of individuals related to each other as closer than the second cousins. Okay, like the example of consanguinity, you see the healthy individuals, but you got the because they were the carriers of the recessive gene, and which did not manifest in third generation, but these on the third generation, their couple and their offspring had this manifestation of the rare disease. Okay, this is the proof of consanguinity is at fault of the repression or expression of the rare recessive disease. Okay, yeah, I will skip this part and you're gonna read it by yourself. I hope, at least. So now let's talk about the types of consanguineous mating. Could be first cousins, as you can see, could be double first cousins like these ones, and these ones could be half first cousins, could be first cousins too, and the second cousins like this. So you get it. Now the inbreeding, okay, not just the ones that share the ancestor, but they share the bloodline, okay. So inbreeding is closely related to consanguinity, and inbreeding describes the situation in which individuals from a small population tend to choose their mates from within the same population for cultural, geographical, or religious reasons. Then here you see the Habsburg jewel. This is the famous Spanish royal family, and usually the royals were the ones that thought their greatness, their power, their influence should be inherited and should within the lineage with their family, within their family name should preserve this. So they mated within each other. So that's lead to the many specific features like the Habsburg jewel that is the result of the inbreeding. Okay, so in this situation, the parents may consider themselves unrelated, but still have the common ancestor within the past few generations. Just as with consanguinity, inbreeding increases the chance that individuals will be homozygous for an allele inherited from the common ancestor. And in taking a family history, it's important to ask not only about consanguinity, but also about the geographical origin of ancestors, especially if a couple is seeking counseling with the similar ethnic and geographical origin. Okay. So this is also another royal family, family Joes, family Noses, and so on and so forth. So with consanguineous mating, it is possible to estimate a coefficient of inbreeding for the individuals in a population, even if they are not to be related with each other in the first place. Also, we make a distinction between consanguinity occurring within a family and inbreeding, which occurs between unrelated individuals from the same small ethnic group. An increased risk for mating between heterozygous carriers of the autosomal recessive disorder exists in both of the situations. Okay, like the Tay-Sachs disease due between Ashkenazi Jews, and I would advise you to read this. This is really, really important and interesting. I'm not gonna read it because I'm so hurting my eyes because yeah, this is the fourth lecture today. This is I will leave up to you and your conscience to read it. Okay. So now let's talk about autosomal dominant inheritance. We said we defined how it's what are the ways of inheritance. We said that more than half of all of the Mendelian disorders are inherited as autosomal dominant trait. It means one mutant allele is enough for the disease to be expressed in the offspring, and 50% are the affected individuals, and 50 period. They're equally distributed within the females and the males as well. Okay, and then this is the pedigree that shows the typical inheritance of the progressive sensory neural deafness inherited as an autosomal disorder. So this mother is the disease carrier that passes it to the son and to the daughter and to the son. So it may half if she had one more. So it was like the half of the children are the diseased one. So it means the disease does not skip a generation. It appears in every generation. Okay. Uh, okay. But of course, the frequency decreases after generation because of the dispersion of genetic material. But still, it appears in every generation. Okay. So now let's talk about incomplete dominance, like in familial hypercholesterolemia, an autosomal dominant disorder leading to premature coronary heart disease. So in this disorder, the rare homologous patients have a um, more severe disease with an earlier age at onset and a much shorter life expectancy than do their relatively more common heterozygous. So it means we have a case of incomplete dominance because the homozygous ones have more severe disease than the heterozygous. I mean, carrying two alleles is the most dangerous, more dangerous than the carrying just one disease there. Still, both of them have disease, but the severity depends on how many alleles they got. Okay, and yeah, new mutations related between new mutations and fitness. This one, okay, I will answer the call and I will have a break to answer the call. Okay, I will be back. That's not the end. Welcome back. This is the last PPT, I promise. I know you're tired, but thank you for bearing with me, Bashir and Marino. Only just us left. And I will open up the final one. Okay, so we talked about the autosome dominant, autosome recessive, and now let's talk about the X-linked, okay? So, whether an abnormal gene is an autosome or it's X-linked, it has a profound effect on the clinical expression of the disease because, as we mentioned, the some disease usually express um, not differently. They are just same according to the gender. Both genders in females and males, they are expressing with the same frequency, no, with the same frequency and severity. But in case of X chromosome, the situation is slightly different because males are nor heterozygous nor homozygous according to the X chromosome. They are hemizygous. So if we're talking about X-linked disease, the males are the ones who will for sure have the expression of the disease. But the females who carry two X chromosomes, if we're talking about X linked recessive disease, they will not have expression at all, right? So the males are 46XY karyotype, females are 46XX, right? But it means they, in terms of X chromosome, they are unequal. Nature is wise, so nature thought of ways of how to equalize this inequality between the females and males and thought of something wise, which is the random X inactivation. Okay, so one of the X chromosomes in the female body is randomly inactivated. Okay, so it becomes a Bohr body, so called the darker spot in the nucleus, which is the Bohr body, which only female cells do have. Okay, to compensate for the double complement of the X-linked genes in the females, allows for the most X-linked genes are expressed from only one out of the two chromosomes of a given cell of the female. So that's called the random X inactivation. Okay, so that's why we've got this different X-linked inheritance. We've got hemizygous males. Big H means a normal allele. Small h means the mutated allele that gives us the affected male. But in case of females, we have three different versions of the inheritance: homozygous X's, which are unaffected; homozygous H's with small h affected one; and heterozygous the carriers, or they are usually unaffected. Okay, but usually doesn't mean always. One X chromosome is largely inactivated in the somatic cells in normal females, but not in the normal males. And this equalizes the expression of the most X-linked genes in the two genders. And the clinical relevance of the X inactivation is really profound, and it leads to the females having two cell population, one in which one X chromosome is inactivated, and one population which the other X chromosome is inactivated. Okay, so I will give you the example. For example, this is the Duchenne muscular dystrophy. So dystrophin is the one protein that holds the carcass of the muscle cells in Duchenne muscular dystrophy. So this is the normal phenotype without carrying any abnormal mutated allele. So this is normal dystrophin. This is the muscle fibers hold together. But this is the abnormal one. There you see no dystrophin at all, and muscles are just losing their self. And here is just the carrier of the mutation, because some of the cells got normal dystrophin, some of the cells don't have the normal one. So this means this part got the X chromosome, which is the carrier of the mutation, and in here in these cells, X is inactivated, which which is the carrier of the normal chromosome. Okay, so it's a normal female, absolutely normal female. This one is abnormal female. It means this is the big H female, and this is small h female, and this one is big H and small h. Okay, heterozygous female will look like this. Okay, but it depends whether it's the disease expressed, how much of the disease allele is inactivated. If instead of these normal ones we've got majority are abnormal, then we will have the expression of disease. So the also inactivation rate is inactivation frequency, how much of the disease X is inactivated, and if it's more than the half majority is active, it means we will still have the expression of the disease. Okay, so, and here are the expression of the X-linked genes with the different variations of the mating. For example, if we have an affected male here, the male which is carrier of the small h is the disease allele. Since the males have only one X, so if the small h is present, it means this one is affected. And here we have a normal female with both of the healthy alleles. So what will happen to their offspring? They will get like this. These are the daughters, and both of the daughters will be the carriers of the disease coming from the father, because father is only able to give the age, and which is for sure the disease allele. So the father will I would say transfer the disease X to their daughters, so they will both of them will be the carrier. All of them would be carriers. But what about males? So the father will not be able to give them X chromosomes. He only gives the Y chromosome to them boys. So the father to son transmission is not possible. All sons will be unaffected. All sons will be the healthy individuals. Okay. But what about if the mother is the carrier of the disease? Okay, father is healthy, so he has only healthy H chromosome, but the mother is the carrier. So mother is also not expressing the disease, but still is a carrier. So mother gives this X chromosome to the one of the boys. It means this boy is affected. It means half of the boys who get X from father will be healthy. The ones who get X from the mother, they will be affected. Maybe 50% of the boys are affected, but what happens in case of the girls? None of them are affected, but the half of the girls are the carriers of the disease, half of them are totally normal. Let's discuss another case. So this is if the both of the affected if the affected disease male meets the carrier mother. So what will happen? This disaster will happen, because now the girl, one of the daughters will inherit both of the X chromosomes from the father and from the mother as well, and these will be homozygous to X, carrying the mutation. So these daughters will be affected. So 50% of the daughters will be diseased, 50 will be healthy, and 50% of the boys will be affected, 50 will be healthy. Okay. So not these ones are not healthy; they are actually carriers. So half of the daughters are the carriers, and half of the daughters are the affected ones, while the half of the boys are healthy, those who got their Y from the father, and half of the boys are the affected, those who got affected L from the mother. Okay. So what are the deduction the out of this? That the father cannot transmit this disease to the son. So father to son transmission is impossible, but the mother transmits it to both of the daughters and the boys as well. And boys will be affected if the mother is the carrier. Definitely will be. So X-linked dominant, the recessive patterns of inheritors are distinguished on the basis of the phenotype in heterozygous females. Some X-linked phenotypes are consistently expressed in the carriers, where the others are not. So, where the disease is expressed in the carriers, it's said to be dominant. When it's not, it's said to be recessive, right? Females who are heterozygous for the some mutant alleles in the same family may or may not demonstrate the disease depending on the pattern of the random X inactivation. Just remember the case of the Duchenne muscular dystrophy. If the majority of the disease X is inactivated, so we won't have the expression of the disease, okay? Because the other healthy one, which is active, will cover up for the inactivated disease one, okay? So now let's talk about expressed phenotypically in all the males. So the X-linked recessive inheritance is expressed in phenotypically in all the males who receive it from the female carrier mothers, and the fathers are not able to transmit it due to the hemophilia type A. Mm, yeah, hemophilia type A, which is a classic X-linked recessive disorder in which the blood fails to clot normally because of the deficiency of the factor VIII of coagulation factors and a protein in protein clotting cascade. Okay, so this is X-linked because this is called also one of the royal disease. Alexander was the one that in the third generation that received the disease from the grandmother who was the carrier, but none of the siblings had the disease, but he was the only boy, and he mm, uh, had this disease and died really young. Okay, so this is a pedigree pattern demonstrating an X-linked recessive disorder, hemophilia type A, transmitted from an affected male through the females to an affected grandson and great grandson. So you see, this man is affected. He married the healthy female, but he transmitted the disease to their daughters because the circles mean the girls, squares mean the boys, blue means the disease, blue dot means the carrier. Okay, so the daughters were the carriers, and one of the daughter gave it to the boy who was affected, the grandson of this man, because none of the boys are affected, as you can see, because the father was affected, but he had all healthy sons, but all the daughters the carriers. Okay, and in this case, one of the son is affected because carrier mother gave it eggs through this, and one of the daughter is also the carrier, so she will pass it down to the great grandson. Okay, in the fourth generation. Okay, that's how it works. So, consanguinity is an X-linked recessive pedigree for the red-green color blindness, resulting in homozygous affected females. So, why the females could be homozygous? Because of the consanguinity. So, like you see, the male who only gave to the healthy sons and carrier daughters. So, why the female here? Because, again, the consanguineous mating, the father and the diseased father and the carrier mother met each other, and now the female diseased one is possible. Not them, just the female is not only the carrier but also diseased affected one, because the two recessive genes meet each other because of the consanguineous mating. Okay, that's the reason why the homozygous affected female occurs from the X-recessive linked disease. Okay, X-linked recessive disease. They are called manifesting heterozygous. So if those rare instances in which female carrier is a recessive X-linked has phenotypic expression in disease, they are called manifesting heterozygous. Still, when recessive disease is expressed in the heterozygous state, is called manifesting heterozygous. Very rare cases. Okay. So the characteristics of linked, we said that the incidence of the trait is much higher in the males and then in the females because of their X inactivation and two X's. And the genes responsible for the condition is transmitted from an affected man to all of his daughter, but none of the sons. And any of the daughter's son has a 50% chance to get it to inherit the disease. Okay, that's a trait of the X-linked disorder. Now, the mutant allele is ordinarily never transmitted directly from the father to the son. So, father-son transmission impossible. But if it's transmitted, then the affected male to all of his daughters. So it's if it's transmitted from father to a son, we are saying that we have a real either we have this is not the case of X-linked recessive disorder at all, or we have something new here or sporadic. Okay, and if the father to son transmitted by an affected male to all of the daughters, so it means all of the daughters will be the carriers of the disease. The mutant allele may be transmitted through a series of the carrier females, as I said. If so, the affected males in a kindred are related through the females, and a significant proportion of isolated cases are due to a new mutation. Okay, just give me a second. So, sorry. So that's it. X-linked phenotype is described as the dominant if it's regularly expressed in the heterozygous. Um, yeah, in case of the heterozygous expression, we are calling it the dominant. And X-linked dominant inheritance can readily be distinguished from autosomal dominant inheritance by the lack of male-to-male transmission, which is obviously impossible for the X-linked inheritance because the males transmit only Y chromosome to their sons, okay, not X. X-linked dominant pedigree is that all the daughters and none of the sons of affected males are affected. That's the rule for the X-linked dominant inheritance, okay? If any daughter is unaffected or any son is affected, the inheritance must be either autosomal and it cannot be X-linked dominant, okay? So let's see the X-linked dominant inheritance. It means the father is the carrier of the disease, giving it to their daughters because it is dominant. It is expressed in the heterozygous. So the daughters are all affected. The sons are all healthy. So now the daughter will pass it to the daughter and to the son as well. But this one only pass it to the daughters because no sons will be affected. So affected males only have healthy sons and affected females, and affected son has only affected daughters and healthy sons. If there is something wrong with that, if there is possible son to son, male to male transition, or if any daughter is healthy of the affected male, it means we are not no longer talking about X-linked dominant disease. Either it's autosomal or something other is going on. So, only a few genetic disorders are classified as X-linked dominant. One of the examples is the hypophosphatemic rickets, vitamin D resistant rickets. This is the O-shaped rickets, and this one is X-shaped rickets because of the deformities. And affected males with normal mates have no affected sons and no normal daughters. So all the daughters are affected, all the sons they are healthy. And both male and female offspring of the female carriers have 50% risk to inherit the phenotype. And affected females are about twice as common as the affected males, but affected females typically have milder expression of the phenotype than the males do. Okay, and there are some rare conditions where X-linked dominant disorder causes male lethality. Okay, some of the rare genetic defects expressed exclusively or almost exclusively in the females appear to be X-linked dominant conditions that are lethal in the males before the birth. That's why the female predominance or prevalence is expressed. Okay, and like during Rett syndrome, which is the striking disorder that occurs nearly exclusively in the females and meets all the criteria for being an X-linked dominant disorder that is usually lethal in the hemizygote males. And the syndrome is characterized by the normal prenatal and neonatal growth and development, followed by the rapid onset of the neurological symptoms and the loss of milestone between 6 and 18 months of the age. The children are spastic, ataxic, autistic, and have got purposeless wriggling and flapping movement of the hands and arms, and that's called the rat syndrome. Okay, and that's the features, clinical features of the Rett syndrome. Head grows slowly, microcephaly, small brain is permanent. Seizures are really common, and surprisingly, the mental deterioration stops after a few years, and the patients can then survive for many decades with a stable but still severe neurological disability. And most cases caused by spontaneous mutations linked with X chromosome, and most of female heterozygotes are full-blown Rett syndrome, while there are no surviving males because of the male lethality of the disease. Okay, so this is the pedigree that demonstrates an X-linked dominant disorder lethal in the male. So there are no males at all. So this is the normal male with the uh, diseased female given a birth to the diseased female, no males at all, not because they don't inherit, but they are simply not surviving the mutation. Okay. Now, yes, the mutations that impair fitness, I'm not going to repeat because I've already talked about this. Duchenne muscular dystrophy that impairs the fitness of the individuals and genetically. And so the DMD, because it has zero fitness, it should be genetically lethal. It means it should just die out in one generation because these individuals are not able to pass on the disease on the next generation, right? Because of the zero fitness. But still, there are striking numbers of the DMD. It means that in case um, so the incidence is not changing. It means the mutant alleles lost through the failure of affected males to reproduce are continuously replaced by the new mutations that occur newly and not inherited at all. Okay. So pseudo-autosomal inheritance describes the inheritance pattern seen with the genes in the pseudo-autosomal region of the X and Y chromosome that can exchange regularly between the of the sex chromosomes, and else for the genes in their pseudo-autosomal region can show male-to-male transmission and therefore mimic the autosomal inheritance because they can cross over from the X to the Y during the male gametogenesis and be passed on from the father to his male offspring. Okay, like the example of this chondrosteosis, that's dominantly inherited skeletal dysplasia with disproportionate short stature and deformity of the forearm, and the greater prevalence of the disease was seen in females as compared with the males, suggesting X-linked dominant disorder, but the presence too of the male-to-male transmission clearly ruled out strict X-linked inheritance. Okay, this is the pedigree that shows inheritance of the dyschondral osteosis due to the mutation of cell autosomal genes X and Y chromosome. So this is the arrow shows the male who inherited disease from the Y, from of his Y chromosome from his father. Yes, this one inherited from his father, not from the mother. Okay. So, and his father, however, inherited the gene from the X chromosome of the mother. Okay. This is the arrow shows the X chromosome. This is Y from the father. Okay, because yeah, that is very rare case, and this one's inherited from the X from the mother, and this one also from the mother. Now let's talk about the mosaicism. Okay, mosaicism is the presence in an individual or a tissue of at least two cell lines that differ genetically but are derived from the single zygote. So mosaicism or X inactivation could be referred as the mosaicism. So it's a natural mosaicism that occurs in the female only and only in the female individuals. Okay. So mosaicism, like in case of neurofibromatosis, that is called segmental neurofibromatosis. It means just a part of somatic cells inherit the disease, so only these somatic cells express the disease, like these neurofibromas that are only on this part of the body, or osteogenesis imperfecta, that highly penetrant autosomal dominant disease, and two or more children born unaffected parents. And this is how it looks like. These are the sorry, I will get it back. So this is the stem cell, and these are cell division and differentiation. So a mutation occurs in one of the cells, and it's transmitted through this one cell to the rest of the cells coming from the same cell um, genetically, and the rest of the cells are just going on developing and replicating normally. Only this line of the cells is affected, okay, mutated, and that's what happens during neurosegmental neurofibromatosis. Okay, that mutation affecting morphogenesis and occurring during embryonic development might be manifest as a segmental or patch abnormality depending on the stage at which the mutation occurred and the lineage of the somatic cells in which it originated in the first place. Okay. Now, this was somatic mosaicism. Now, let's talk about the germline mosaicism. It means the chance that autosomal or X-linked disorder caused by a new mutation could occur more than once in two species is low because of simultaneous mutations are usually very rare, and such unusual categories can be explained by the germline mosaicism, which is and inherited yeah inherited in the progeny. It's shown in the progeny, unlike the somatic one. Somatic one only in affected one mutated the person has. It's not inherited somatic mutations and mosaicism. Okay, so according to the Mendel's law of heredity, a mutant allele of an autosomal gene is equally likely to transmit the mutated other sex. And similar, a female is equally likely to transmit mutated X-linked gene to a child of both the male and the female. Originally, little attention was paid to whether the sex of the parent had any effect on the expression of the genes of the parental transmission, but in case of the Prader-Willi syndrome and Gamma syndrome, the expression of the disease phenotype depends on whether the mutant allele has been inherited from the father or from the mother. That is called phenomenon of genomic imprinting. Like in case of the mitochondrial disease, like mother is important player here. Mother is the one that can transmit the disease. So maternal imprinting is the example of the mitochondrial genome disease. Okay. Yes, and unstable repeat expansions. It means three nucleotide repeat expansions, like with Fragile X syndrome, like Huntington's disease, cerebral spinal ataxia, and so on. Like CAG, CAG, CCG, CCG, like this expansion of the sequences are the cause of the disease, and as the frequency of the sequences increases from one generation to the other, the severity of the disease also increases, and also abnormality onset also gets younger. So the how to say the age onset is shifted. It means younger individuals get to manifest the disease, like this Huntington disease, spinocerebellar ataxia, Fragile X syndrome, myotonic dystrophy, and Friedreich ataxia, which is the cerebellar ataxia. Okay. And here I have the Huntington's disease, which is the well-known disorder, autosomal dominant disorder, many common genetic features of the follicle disorder caused by expansion of the unstable repeat, and the patients have chorea, atotosic movement, involuntary movements in their extremities. Individuals are really young and they cannot perform many jobs because they've got on this involuntary movements, and they get more severe and severe, and they disturb their normal lifestyle. And as much as the individual, this son and grandson, will have much more severe form of the disease, and the onset in them will be of the disease will be much earlier in the next generation, because the expansions this because of this trinucleotide the frequency of them expands within the next generation. Okay. So spinal bulbar muscular atrophy. I would like you to read this part by yourself. I will just skip it. And Fragile X syndrome, which I have discussed in a previous, and this is the X chromosome with the fragile side. This fragile is like decondensed, the light part in the electron microscopy, decondensed part, and this is the most condensed part, which is the dark heterochromatin and euchromatin. Okay. Sorry. Myotonic dystrophies. I have here Friedreich ataxia, which is very severe, and there's a Japanese movie about it. 10 liters of tears I got. Oh, 10 liters. Yeah. Mitochondrial genome. So last thing, and we'll be over. So mitochondrial genome consists of the circular chromosome, one with the, of course, it's different from the nuclear one, and not most of this contain at least 1,000 mitochondrial DNA, empty DNA, and distributed along the hundreds of individual mitochondria, and they pass down from generation to generation through the oocytes. Okay. Female germline cells. It means the only maternal mitochondria get to be inherited, but the spermatozoids also got mitochondria, but they are destructed, and they just die off, and they are not transmitted to the progeny. Okay. So the remaining polypeptide of the oxidative phosphorylation complex are encoded by the nuclear genome, and more than 100 different arrangements, 100 different point mutation identified in the mitochondrial DNA can be the cause of human disease, and like Leber's retinopathy. And maternal inheritance is the way of inheritance, because sperm mitochondria are generally eliminated from the embryo, so that the mitochondrial DNA is inherited only from the mother ovum. Okay, all the children of a female who's the homoplastic, so we cannot say the heterogenic or homogenic, heterozygous or homozygous. When we're talking about mitochondrial DNA, the mitochondrial genome, we are saying homoplastic or heteroplastic. What does that mean? It means homoplastic, it means they have like similar, all the healthy mitochondrial, all the diseased one. And heteroplastic means half of them or some amount is healthy, the other part is unhealthy. Okay, depends Yeah, depends how much of them is healthy in order to be mitochondrial disease to be expressed. So it's a replicative segregation, which of the mitochondrial genome is descended on the offspring, and we've got homoplasty and heteroplasty. You see here, these blue ones are affected ones, and these ones are normal ones. You see, blue ones are majority here, only one in one type of the cell. Here we've got four gray ones, more than, and like this is the gray is a majority. So this is the normal phenotype because majority mitochondria is normal, and this is the disease phenotype because majority is the diseased one. Okay. So this is the random segregation resulting in the homoplasty and heteroplasty of the mitochondrial gene. Okay, and this is inheritance. This is Leber hereditary optic neuropathy, one of the well-known rarest mitochondrial disease, a form of spontaneous blindness caused by the defect in mitochondrial DNA. Leber hereditary optic neuropathy. Inheritance is only through the maternal lineage, so the father will not give it to any daughters or any sons. Just the disease will die out in this generation, but the mother will give it to all of the offspring. Every generation has a diseased person. Okay, and this lineage also will carry out the disease. Okay. No affected male transmits the disease, but all affected women, mothers transmit the disease. Okay, at some point. Okay, that's all I wanted to talk about for today. I know it was too much. My brain is fried, and I know yours too. Ears, I suppose too. Thank you for bearing with me. Thank you for.
Thank you so much, Krishna. It was really good.
Bye bye. See you next week. That's
See
gonna be the
you next
final.
week. Bye.
Thank you. Have a nice weekend and have a nice
You
week.
too. Bye.
Thank you.